Nick Majerison here, welcome to TopMed Talk. And it's time for us to continue our series of EBPOM 2018. Some of the talks recorded at the Institute of Engineering and Technology at the beginning of July. Today's talk is Michael Englesbe, Driving Value in Perioperative Care, the Michigan Experience. Have a listen.
TopMed Talk.
It's an honor to be here. Are there any other surgeons in the room? I know Julie, so one. Thank you. Nice. So stick with me, okay? I don't care about fluids. Give our patients the right amount of fluids. I come to these meetings because I do a lot in quality improvement across my state in Michigan, and a lot of the things that you talk about, surgeons don't care that much about. So as a result, you can make pretty big impact pretty quickly because they don't care. And I don't know how to say, telling a colorectal surgeon to do it robot or lap or whatever, they get very emotional about. But fluid resuscitation, pain control, prehabilitation, things like that, you can make some progress. So I'm a surgeon. I'm at the University of Michigan. Michigan's kind of best known for football. We have an anesthesia department, which I work very closely with, and we have a department of surgery. And we hold the responsibility across our state to improve care. And we have a very unique relationship with Blue Cross and Blue Shield of Michigan. They're the private payer. They pay for about 40% of the care in Michigan. And then the state of Michigan, Medicaid, which is kind of for our at-risk population, about 10% of care. So about half, a little more than half, about 55% of the care, they essentially pay us to make care the best it can be in the state of Michigan. So it's physician-driven quality collaborative. So we collect data on most people who have surgery in the state. There's an anesthesia collaborative, Sachin Ketterpal runs. There's the surgical one that I run. There's one in orthopedic surgery, cardiovascular surgery. And we are very lucky to have this infrastructure for data collection and practice change. There's 71 hospitals that do major inpatient surgery in Michigan. Michigan's a pretty big place. There's 10 million people. It's about average demographically for the United States. Down where all the people live near Detroit, Ann Arbor's kind of over here, to way out there in the what we call the Upper Peninsula. It's about a 550-mile drive, so I actually just looked. It's further from here than Aberdeen, Scotland. So it's actually a pretty geographic place, and we have very rural places. We have very urban places. We have some kind of tough cities like Flint, Michigan, Detroit, and we have some affluent areas like Ann Arbor and some of the surrounding Detroit areas. So we kind of have a little bit of everything. It's a good place to have surgery, and I don't mean this to brag, but we've been cranking with this relationship for over 10 years about kind of improving care. And, the average length of stay for colon surgery is 4.9 days. In the UK, I just saw a day it's about 7.2. In the United States, about 7.4. That's one measure of quality, but I'll say that within a large population, a very diverse population, I think it's just one measure to show that care is pretty good in Michigan. We have a statewide program for rehabilitation. We have opioid prescribing recommendations. We have an infrastructure for patient-reported outcomes, and we have care pathways. And I'll point out the patient-reported outcomes infrastructure and the opioid recommendations came about because of our collaboration with the Anesthesia Collaborative. Somebody from WashU talked about patient-reported outcomes. One of our colleagues talked about opioid epidemic about 5 years ago, and it really motivated our collaborators, and particularly our surgeons, to care about these things, and in a space where surgeons can have a big impact. But what I'm going to mostly talk about today is care pathways. And I frequently talk about how do you change practice. And we're here at evidence-based perioperative care. But I'm somewhat cynical that any of this matters because of that slide of Julie's paper where you're showing that some people are getting 22 liters of fluid with their colon surgery. And I think we all know that the variation in care is huge between the University of Michigan and that hospital 550 miles north. And how do we kind of bring that down so that the average patient in our state can get great care? And this is how I explain how we think about change. I think about global warming, and I think about plastic. So plastic's bad for the environment? Raise your hand. Yes? Yeah, they are. So there's been a lot of information lately on how they're bad. Have you changed? You've got, this has been all over National Geographic. Have you changed how you've dealt with plastics in your life in the last 2 months? Probably not. Maybe some people. Good for you. I haven't. I tried. So there's data around. This is like the randomized trials. This is the data part. And we all know that between practice and data, there's a huge amount of space, right? But right now, my point is plastics are bad for the environment. About 2 months ago, my daughter had to give a talk. She's 14. She's very shy. For her to give a talk is a really big deal for her and her family. and her father, and she came to me in tears, "Dad, will you help me?" She was talking about plastics and implications on the Great Lakes. And it was just this remarkable parental moment where your 14-year-old daughter is actually talking to you, and I'm helping her. And I learned a lot about plastics. I kind of really saw a little bit of the greatness of my child, which is hard to see when they don't really talk. So that's the emotional piece, my emotional tie to plastics, right? So plastics data, okay. The emotional piece, we talk a lot about the way we change practice. So a couple days later, I'm going to Starbucks, and I'm like, all right, I'm off plastics. I care. I'm all in. I care. Right here, I care. I got my regular coffee, and I said, no plastic lid, none of that. I don't want that plastic stopper. I don't do plastics anymore. And I'm kind of walking out, you're like, oh, and I pour half of it out, get in my car, and drive to work. Treacherous situation. The point is that I can't get off the lid to my Starbucks cup until Starbucks changes the way they package their product. So this is my point. The care pathway, the pathway for change, is the secret sauce. Data matters. We have to care, and we can care by incentivizing physicians. But the key in the magic sauce is the standard care pathway. And in surgery, we don't have clinical trials, rarely, maybe in cancer surgery to a certain degree. And the variation in practice is huge, and you know that just seeing one surgeon and another coming into the room. So this is how we do change. We do look at data. We have data from almost everyone who has surgery in the state. We've been having that for 10, 12 years. I don't think it matters that much anymore. We've kind of squeezed all the juice out of their data. We talk a lot about our community in Michigan and changing practice and why you should care, and we financially incentivize that. And that's a big thing in the United States. But we use care pathways to try to change practice. So I'm going to show you a little case study of how we change practice. And this is all within the last year in a population of 10 million people. We got interested in the opioid epidemic. We generated a lot of data in patients in Michigan and national data on this premise. These are 6 different papers that we've written, 7 papers. And the concept is this: new persistent opioid use. So as a surgeon, we now say the most common surgical complication in Michigan is taking an opioid-naive patient and leaving them as a new chronic opioid user. That's probably just an American problem. I don't know about your health systems, but that's a devastating number. 6% after relatively small operations. You look at the different types of operations, it's higher or lower. Look at pediatric surgeries, 5%. It's an unbelievable number. And this is data. Most of it's from our state, some of it's national data. It's big data, has lots of limitations, but it's certainly important. But then we change our tune to try to change practice, say, why does this matter? And we talk about my day job as a liver transplant surgeon. So I'll tell a story of this is opioid overdoses and organ donation in the state of Michigan the last 10 years. It's gone from 1.6 up to almost 17% of organ donors are opioid overdoses. And I tell a story about one day 4 years ago, I had 3 donors in a row. I was on call. And the first one was an opioid overdose after a young woman who had had wisdom tooth extraction. The next one was a young woman who had had a high school sports injury. And the third one was a young woman who had leftover pills from her parents, graduation from high school. 3 in a row, opioid overdoses. Why do I tell you that story? Because in Michigan, we care. We care about that. And then we talk about leftover pills. We talk about the biggest factor that would determine how many pills you took after your surgery is how many pills I gave you. In the United States, surgeons do all the postoperative prescribing. Dentists, surgeons, emergency room docs. So we write for lots of these things. But what we do is we show the pathway for change. For opioid prescribing, we have data flows, we have patient-reported outcomes. We know how much people are given, how much they took, and we come up with recommendations. And this is a complex chart because every 3 months we reduce the recommendations because people are taking more and more because we attack this around best practice. But I'll just show you what we've done on lap chole. This is lap chole in the state of Michigan. This is 2015 down to November 2017. That's about 45 pills of Vicodin oxycodone. It's a lot of pills. You probably say, oh, we don't use that many. You might. This is millions of people. And this is how we change practice after we had a recommendation around opioid prescribing. Why did that work so well? Because of the Starbucks analogy. Also, as surgeons don't care that much about this. I'm not telling them how to do surgery. I'm telling them how to change a relatively small piece of the practice. And also, our recommendations, basically, we write very specific care pathways that are for nurses who do 99% of the care, and we know it's true, at the bedside, or post-op discharge information. So how do we change practice in Michigan? I have about 2 more minutes. Michigan value-based care pathways. So we know who does the best lap choles in our state. We have 71 hospitals. We pick out those 3. We ask them, how do you do it? Stem to stern. From introduction to the patient, how do you talk to the patient? How do you do the operation? How do you do the anesthetic? What do you do at the time of discharge? And very, very specific. People think, we don't want to tell doctors what to do. It turns out most of us are pretty lazy. If things we're not emotional about, we just kind of want to be told what to do. The way I feel about fluid resuscitation. Just tell me what to do. Colon surgery, inguinal hernia, hysterectomy. So we know who the best practice performers are. We have a Michigan pathway. This is the best practice in the state of Michigan. This is how we think it should be done. We take it to all 71 of our hospitals, and this is what the surgeons need to do. They need in hospital, so it's called St. Mary's Hospital. Here's the Michigan pathway. You all have to sit down. And you all have to sign off on it. You can edit any component of it you want. And that's really important. We're not taking away your autonomy. But you need to be in the same room. And at St. Mary's Hospital, this is the way we do a lap chole. In St. Mary's Hospital, this is the way we do a hysterectomy. And we all know in things like transplantation or cardiac surgery, it's not a one-off. It's always the same way every time. Trying to get that care pathway standardized. At the end of the year, they have to sign off that they did it. And they have to meet some process measures, relatively small number that we measure. There's financial incentives. If you do this, you get paid 3% extra on your surgeon's fee, which is real money. Average surgeon in the state of Michigan does about $250,000 of business for Blue Cross. Whatever 3% is, it's like $10,000. It's real money. But more importantly, some of these cases, you do the hard-to-reach stuff. So you do a lap chole without opioids. You do a hysterectomy and some people home with 2 pills. We pay 35% extra to the surgeon. So we try to align that decision I made about putting the plastic cup with the actual financial incentive, which no one can really do. And that's kind of how we try to change practice in the state of Michigan. We've had a lot of success so far. And part of that, I think, is critical is our partnership, because a lot of the good ideas come from our anesthesia colleagues, but a lot of the practice change need to happen among surgeons. So thank you.
And don't forget you can meet the Top Med Talk team. All you need to do is turn up at one of our events. Check out ebpom.org for more details. ebpom.org. Our next big event is between the 28th and the 30th of September in Chicago. That's EBPOM USA, the Chicago Masters Course, Perioperative Care Practicum. Between the 28th and the 30th of September. ebpom.org for more details. That's ebpom.org.